Hotbed Talk.
Professor Franco, otherwise known as the father of prehabilitation. Franco is Professor of Anesthesia at McGill University in Montreal. He has been one of the lead organising committee with us and with Herritt for this conference. And he is also the first honorary life member of the International Prehabilitation Society. So can I welcome up Professor Franco, please? Thank you.
Thank you. 2 minutes, right?
Okay.
Thank you very much. And this is quite interesting. Last year I was the grandfather, so now I'm younger. Right. This morning I crossed through the gate of the British Museum, and I tell you it was some trepidation. Also because when I was in London for many years, I used to come to the British Museum almost every month with my children. And it's like something feeling the sense of being in sort of historical antiquities, but this is history which actually helps us to continue forward our principles. So they asked me to talk about how far away we come. And I thought that is really, I remember about 7-8 years ago, we really were the new kid on the block. We didn't know very much what to do, and surgeons and anesthesiologists knew a little bit about. But I think now we're coming to really to be the star of perioperative medicine, which I think is great. It's good news. So I will probably start with some considerations today to pose to you. And basically some are successes, but I think there are challenges there. And I will start very much with the first one, which is really, in my view, we're shifting the paradigm. And I'm going to surgeons' meeting, and it's quite interesting. The surgeons are becoming more interested in a sort of value. And in this case, seems to accept the concept functions. Functions for the patient matters. Matters to the patient, of course. Now, this is an interesting study years ago. This systematic review was done in our center, where we looked at the evaluating recovery after surgery. And what is interesting, if you're looking at the slides, is very much that really we have been studying a lot the biological, physiological, the symptoms. When it comes to quality of life, out of 38 comparative studies, very little on quality of care or quality of life and general health perception. But even more interesting is this study where they actually look at what are actually important for the patient. They'll ask 17 patients and clinicians what they felt about all these metrics, all these outcomes. And it's quite interesting. The patients emphasize energy, functional status, and routine. What actually they can actually do. And while the clinicians were more interested in pain, bowel function, cognition, which is important too. So I would really pose to you this question. Should we really continue to value very much the concept of function for the patient is patient-centered? I suppose so. And that's what prehabilitation could come forward very much formally. Now, there is a very good editorial by the surgeon, Thomas Robinson in Colorado, who actually wrote in a function is an outcome meaningful to patient. It was a very interesting studies. And why I want to quote this, what a few words interesting. Number one, patient-centered outcomes. We are moving very much to the concept patient is the center of care. Second one, function is an outcome measure. And third one, a function provides a concrete and meaningful variable for patient because it represents the ability to maintain living at home and avoid institutionalization, which is so essential for patient to be at home and be mobile, independent. Then I'm going to the second success, trial and publication. I can see very much a lot of you here. Many of you is interested. They come here for curiosity. Maybe some of you actually are doing studies, which is great. And we know the number of trials and publication is increasing dramatically because prehabilitation works. Seems to be that what is coming out from the publication, yes. So this example from our place only, which shows that increasing function. We only look at simple function like 6-minute walking test in oncological surgery, in different whether this is colorectal or prostate or in esophageal or cystectomy. We see really a sort of functional effect, functional recovery is better if you actually do prehabilitate in these patients. We'll hear today and the next and tomorrow all various facets of the prehabilitations, from exercise, nutrition, medical care, and so on. You will hear all the larger studies done, but very much to what I'm doing here is really a panoramic view of what I think is happening and some proposal to you. This is the latest one, major-abdominal surgery, and they actually look overall morbidity and mortality and pulmonary morbidity. As you can see, they are good sign, good signal that there are some effects of prehabilitation. But what is interesting is that I would say there is signal there. They probably are actually changing something. This is a study coming from our friend in Southampton, where actually exercise prehabilitation lead to an augmented tumor regressions. And this is published in Oncologica. This is followed by our paper. We actually show in Annals of Surgery, is going to be published soon. We actually improve disease-free survival, especially in after colorectal surgery, in prehabilitation, in stage 3 only. So there is an indication that probably these are the patients we are actually potentially benefit from. And that's, I think, is the signal, is an association, of course, is no causality, but it's indicated that something is vital, moving in that direction, which is great, it's positive. Now, as you probably know, I don't know many surgeons are here, but definitely one of the preoccupations of surgeons and also institutions, not only countries, actually dictate that the colorectal cancer should be operated within 2 weeks, 3 weeks, whatever. Now, this is a study. There are 2 studies, one just published last year, which actually show that time from colorectal diagnosis to laparoscopic curative surgery, whether it's at 4 weeks or 8 weeks or 12 weeks, doesn't change the outcome at 5 years. So that's a huge help to us justify to our community, surgical community, and in fact, there is a positive aspect in some patients, surgical patients, targeting patients, they can actually do something and they can benefit. This is another study coming also from our place as well. We actually show that if you, in stage 3, stage 1 and 3, whether you delay by 4 weeks or 8 weeks or more than 8 weeks, the difference is not very much significant. So I think that helps you to bargain with your surgeon. And when you think the patient is not fit, that I think we should say so. I think we have the courage. We have to have the courage to actually come forward. Now, and the third point, which I think is successful, is a collaborative work. And I love this paper. I always cite this paper for the last years. And I think you should read the New England Journal of Medicine 2014. There are 3. One is a surgeon, one is an anesthetist, one is an intensive care physician. And actually talking about redesigning the surgical decision, especially for a high-risk patient. And I think that's what we're dealing more and more because of lifestyle changes. We're dealing with these patients who are really coming through the door and they really are high risk. Should we operate? Should not operate? And I think they're quite interesting, the comment in putting red, striving to make surgical decisions make more patient-centered and accountable. And their point, why don't we establish like a tumor board, a multidisciplinary team, which is this the concept of tumor boards. I think I love it as this idea, where in fact all the physicians get together. And the team could help to coordinate preoperative assessment, optimization, and so on. So this is where I think we should change the practice. And my view, coming from a culture of enhanced recovery after surgery, where actually we started in 2006 at McGill, we found very much the whole paradigm changes. The surgeons are changing, the nurses are changing, anesthesiologists coming as well. So that's where we have to be us, the charismatic and champions for this. And then I go to the challenge. And I chosen three aspects. One is the frail patients, and that's is close to my heart because I think this is really we have probably pose much attention to this group. And I'll show you something. This is June 7, 2019, very recent, as you can see. New York Times, the elderly are getting complex surgery. Often it doesn't end well. So the American College of Surgeons are coming up now with a project where actually hospital for operating for surgery, they have to a geriatrician and so on and so on and so on. Now, I don't think we need that. I think we need a good identify the patient at risk, the elderly. Why is it so important to this frail elderly patient? And I'll show you this concept of where you have, on your right side, you have a frailty. Now, we use many words for frailty, classification for frailty. I like to use this concept of where you have, on one side, this concept of frailty, deficit accumulation, fatigue, sedentary behavior, that you identify, the surgeons identify weight loss, and they send it to you, cognitive impairment. But at the other side, you have the sarcopenia, which actually is the muscle loss, the actual physical and biological element. And then, of course, this overlap, which actually is done by the physical component, the physical and functioning impairment. And that's where you have both together creating this weak muscle strength, slow gait, poor balance. That's where the combination of these two concepts altogether will really identify in the phenotype, which is what generally happens with frail patients. But be careful, because when you categorize frail patients, I'm not going to talk about how you assess it, because there's going to be a talk on this one by a geriatrician. I would like to actually show you what actually happens every time there is an insult, like an insult, let's assume whether this is surgery or trauma, fracture of whatever, femur. Basically what is actually happening, this limb muscle mass is decreasing, either because of the effect of surgery. But these hits are really catabolic crisis. So these patients are actually deteriorate every time there is an event like surgery or maybe a complication. So should we bother? I think so, because I'll show you what we did. We looked at a group of patients who are frail, and we divide in frailty score 2 to 3 according to classification well known, and then 2, 3, and 4 or 5. So from 0 to 5. So we decide to take 2, 3, and 4 and 5 because they represent very much the patients at risk we know in surgical patients. That is validated. But just to say, then we looked at the nutrition aspect. So SJ is a nutritional assessment. Menu dietitian probably will recognize here. A well-nourished, B, a nutrition risk, C, malnourished. And we looked at the composition of these patients in frailty 2 and 3 and 3 and 4. As you can see, if you are C, definitely you have 40% of your malnourished. So this is the category of patients 4 to 5. We feel that really are at high risk. And how we looked at, then we decide to look at a 6-minute walking test. As you can see, the one who are actually for file IV not even get to 200, 300 meters. So rarely are a severe risk. When you think about, probably you would expect something around 400 meter, at least walking capacity. And when you look at hand grip strength, even lower. So 18, which we know is the limit, 16, 18 is the limit of where malnutrition actually. So this is the patient I would like to actually take care. And there is any data on that? I tell you, very little. I'm ashamed that the community, surgical community, or our community has not paid attention to this. And the mortality is very high, we know, in elderly. I don't need to show the data, you will hear that. But what is interesting is about this paper in PLOS. Actually, they look at the intervention to improve outcome of frail patients. They look at systematic review, and I can tell you there are only 11 studies. And as you can see here, they divide in exercise. As you can see some here. Of course, the bubble, bigger the bubble, the more studies than in cardiac orthopedic, of course. Care protocol, well, these are very much geriatric assessment, geriatric manipulation, cognitive aspect, and so on, but not really aggressive treatment. And then, of course, this transfusion. As you can see, very little has been done in this area. So, collegially, we have to tackle this issue. Second one is engaging patient. One of the difficulties I have, and I'm sure all of you have, is actually engage patient in the prehabilitation. And we're talking very much. And we know that it's difficult. Is it an art? Well, let's have a look. Definitely, a patient who are engaged, by definition, have a high level of satisfaction, understand their care, and improve health. Not only that, but they actually participate in the sharing decision. That's what we want now. Patients have to share their own decision, have a care plan, and understand the criteria to participation. So I would like to actually pose to you this dilemma that we have. 30%, 40% of patients do not comply. Well, the Canadian Patient Safety Institute looked at different level of engagement, from direct care, I would say bottom up, directly to patients. Organization, you can actually structure within the hospital with your nurses, your health system, or you can do a policy from the government, let's say, from Institute of Health. And then you can inform, you can consult, you can partner. I think this is crucial in this continual care or engagement, which makes sense. The question is that, what can we do to improve patient understanding? And that is the challenge. Do patients understand what we are actually talking to them? Should we test the health literacy level? So the definition of health literacy, and I'm sure many of you probably know, is the degree to which individual can obtain, process, understand basic health information, and then services, and they need to make appropriate health decision. Well, the situation is pretty bad. In US and Canada, 40 to 60% health literacy is. In Europe, it's 45%. So we're not doing very well overall. So is that our fault? Is it a problem? What do we do? Especially in prehabilitation, it's so important because we're still offering something like exercise or smoking cessation, behavioral, which is very difficult. Sometimes patients say no, but probably because they don't understand or we're not be able to actually offer them as a medicine, as a prescription, instead of an option. Well, let's have a look a little bit more. Patients with low health literacy, you will see them immediately when they come to the Prehab clinic or your surgical office. They fill registration forms incompletely or inaccurately because they don't understand. They miss appointments. They fail to follow through laboratory tests, imaging tests, or referral. They forget about. And be unable to name their medication. How many tell you, oh, it's a blue pill, it's a pink pill, and so on. Explain what they do, what they use it, what it's for. Well, can we improve the patient's engagement? Let's have a look, some strategies. What about using plain language? And I will show you, what about using some videos or using some leaflets that are really being seen for health literacy for level 5, not L5, 11. Second, what about eliminate distractions? When you see your patient at the same time, what do? You answer your phone and so on. It's very common. What about using the simple things? The 3 single questions. What is my problem? What do I need to do about it? And what is important for me? And what about use the teach-back method? So I want to be sure I explain everything clearly. Please tell me in your words what you heard me say. Very powerful. When you go home tonight, your wife or husband or family member might ask you, what do we have discussed, just to make sure that I have explained clearly. Can you tell me what you will tell them? Takes time, I know, but it's very important for them. And the other one, avoid acronym. Instead of using physician, accelerate, approximate, consume, why don't we use doctor, speed up, about, eat, start, change, instead of utilizing, use, implement, do. It seems to be logical. So there are definitely in each hospital In each institution, there are nurses who are actually dealing with health literacy. So use them if you want to make a booklet and so on. And the last one, universal precaution. Universal precaution comes to the concept that if I see a gentleman in front of me, a patient who has university, I'm not using the university language. I'm using the universal language, which I use to everyone, level 5 or 6, not a level 11. That's universal precaution. And then train your staff. So we have sessions with our nurses who are in health literacy, and she educates all of us. I think it's important that we have a common understanding. So organize that. It's easy to do it. You can do it. And it's very useful, I can tell you. We haven't actually tested, but we've done testing in ERAS, in enhanced recovery, and it's been quite useful. The last challenge is Prehab and continual care. And then I'm spending just a few seconds just to say the ERAS program that you all know, I think really you look at the pre-admissions, classical pre-admission, preoperative, intraoperative, which to some extent, in my view, they are working a little bit silos, but less silos. And then, of course, I think what I'm proposing to you is that stop the silos, even in prehabilitation, even more. And that's what we have been trying to do at McGill. This is sort of, I would say, a program we propose where, in fact, we're lucky that our preoperative clinic, which is staffed by these people, we have actually the same corridor as the prehabilitation clinic, where we have these people who actually interchange very much. The surgical clinic is here, send the patient directly to us or to them, depends very much, and then we interact with us. But this is the platform, which is available on the floor. And that is emphasized very much all aspects of the care. So I finish with I say that thank you very much for listening to this one. This is really a setup for the next day or two discussion about various aspects of the prehabilitation clinic. And with that one, thank you very much.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.